I'm Dr. Rahul Agda. So today we are going to see about how do we approach a patient with a LFT report and also how do we diagnose a patient with chronic liver disease. So whenever we see LFT report, we should know that liver function constitutes a synthetic function of liver. That means it causes synthesis of albumin, globulin and coagulation factors. Then there is a excretory function because it is causing conjugation and excretion of bilirubin. And then there are certain enzymes which are released in the blood if there is a liver injury, right? So we should broadly categorize liver function test into these three broad headings and then review the LFT, right? So let us first of all talk about how do we approach when a patient presents to us with jaundice, right? That means increased bilirubin. So the step one, whenever a patient comes to us with increased bilirubin, is to look at the liver enzymes, right? So whether the liver enzymes are elevated or not. So if the liver enzymes are normal, that means it is just a case of isolated elevation of bilirubin, right? So the next step here is to look at whether the direct bilirubin is forming more than 15% of the total bilirubin or not. If the direct bilirubin or the conjugate bilirubin is forming more than 15% of total bilirubin, that means it is a isolated conjugated hyperbilirubinemia, right? And if it is not forming, that means it is a isolated unconjugated hyperbilirubinemia, right? So what could be the causes of them? So isolated conjugated hyperbilirubinemia means liver is conjugating normally, but it is not excreting it out, right? So that would happen in Dubin-Johnson syndrome and Rotter syndrome, which are congenital defects in excretion of bilirubin from the liver, right? Next, what could be the causes of unconjugated hyperbilirubinemia? So that could happen if either there is increased synthesis of unconjugated bilirubin, so increased load is being present into the liver and therefore liver is not being able to conjugate it entirely. That can happen in cases of hemolytic anemia, a large hematoma or a lobar pneumonia, because all of these conditions would have increased RBCs that would undergo hemolysis and therefore increase production of unconjugated bilirubin, right? Next, there could be reduced uptake in the liver. That can happen in Gilbert syndrome or it could be acquired due to drugs like rifampicin, decreased uptake in the liver. Third, it could be because of a UGT enzyme deficiency, which is the enzyme causing conjugation of bilirubin. So this enzyme deficiency can again be congenital in Crigler-Najjar type 1, Crigler-Najjar type 2 and Gilbert syndrome, and it can be acquired in breast milk jaundice. Breast milk has certain fatty acids that inhibit this enzyme. Also, breast milk contains antibodies that can inhibit this enzyme. So when this is happening because of these antibodies, it is known as Lucy-Driscoll syndrome, right? Both of these conditions are self-limiting, right? Now, apart from this, it can also happen because of drugs like gentamicin and clariphenical, which can cause acquired UGT enzyme deficiency, right? So in all these abnormalities, there is normal liver enzymes. Now, what if the liver enzymes are also abnormal? So the next step is to look at what is the pattern of injury, whether it is a hepatocellular injury or whether it is a cholestatic pattern. So hepatocellular injury would have elevation of SGOT and SGPT. So what could be the conditions? Acute viral hepatitis, drug-induced hepatitis, ischemic hepatitis, and all the causes we discussed in the last video of chronic liver disease, alcohol, non-alcoholic fatty liver disease, metabolic causes like Wilson's and hemochromatosis, all of them will cause a predominant hepatocellular pattern of injury, right? In these first three causes, they are very specific when the SGOT and SGPT are elevated more than 1000 international units per ml. Then we should think of acute viral hepatitis, drug-induced hepatitis and ischemic hepatitis, right? What if there is a cholestatic pattern of liver injury? That means ALP and GGT are predominantly elevated. In that step, in this case, the next step is to get a ultrasound done, right? So if the ultrasound shows dilated CBD, that means it is a surgical cause. There could be a stone, there could be a malignancy obstructing the CBD. So in that case, the next step is to get a MRCP and an ERCP done, right? If the ultrasound shows CBD is not dilated, that means either the intrahepatic bile duct is there is an obstruction in the intrahepatic bile duct or there is a sclerosis of the entire common bile duct. So in that case, we'll get a anti-mitochondrial antibody test done. So if the anti-mitochondrial antibody test is positive, it goes in favor of primary biliary cholangitis. And if it is negative, then it goes in favor of primary sclerosing cholangitis. So one important point to remember here is both of these conditions, We discussed in the last video that fatigue is the most common symptom of chronic liver disease. In both these conditions, fatigue is out of proportion to the severity of disease. Patient would present with extreme fatigue. Also, in this cholestatic pattern of liver injury, the enterohepatic circulation of bile, the secretion from the liver and then reabsorption from the intestine is affected. So this will affect the absorption of water soluble vitamins which happens together with bile. So that would be hampered. So therefore, in this cholestatic pattern of liver injury, we would see vitamin A, D, K deficiencies, which are fat soluble vitamins, right? So there would be vitamin K deficiency, which would manifest as a coagulopathy, right? There would be vitamin D deficiency, there would be metabolic bone disorders, right? So these would be predominantly seen in liver disease with a cholestatic pattern of liver injury, especially in primary biliary cholangitis and primary sclerosing cholangitis, right? So this is about how do we approach a patient with elevated bilirubin. This is a one chart which summarizes the entire spectrum of illness with the elevated bilirubin, right? So now let us approach the abnormalities further. So moving on to the next part, we talk about the synthetic functions of liver. So I discussed that synthetic functions are three, right? Number one is albumin. Number two is globulin. And third is the coagulation factors, right? So if we talk about albumin, it is synthesized exclusively by the hepatocytes and it is a half-life of 18 to 20 days, right? But it is not specific for liver disease because it can also be low in protein-losing enteropathy, in nephrotic syndrome, and in chronic infections where there is a prolonged release of cytokines and therefore albumin is low because it is also a negative phase reactant, right? So apart from cirrhosis, all these conditions will also cause low albumin, although it is specifically synthesized in the liver, right? Next, we move on to globulin. So there are two types of globulins. Gamma globulins, which provide a role in immunity, are produced by B lymphocytes, and alpha and beta globulins, which are produced by hepatocytes. But in patients of chronic liver disease or cirrhosis, gamma globulins are elevated by because there is translocation of gut bacteria in the liver, which is normally cleared in a normal liver, but in cirrhotic liver this is not able to clear these gut bacteria, and therefore B lymphocytes produced globulins against these bacteria, right? So therefore in all these causes of cirrhosis there is elevated of gamma globulins with some specific isotopes like IgM is specific for primary biliary cholangitis. Autoimmune hepatitis के अंदर IgG will be seen. Alcoholic liver disease में we will see IgA elevation, right? So these are the gamma globulins which can be found elevated in specific causes of cirrhosis of liver, right? Now moving on to the coagulation factors. So all coagulation factors except factor 8 are synthesized in the liver. Factor 8 is synthesized by vascular endothelial cells and they have a short half-life. So because of the short half-life, measurement of clotting factors, specifically the prothrombin time, is the single best accurate measure of hepatic synthetic function, right? So this would give us the most acute picture of liver dysfunction, right? Coagulation factors. And marked prolongation of PT more than 5 seconds above control and not corrected by parenteral vitamin K is a poor prognostic sign in acute and chronic liver disease, right? So these were the three synthetic functions of liver: albumin, globulin, and coagulation factors. Now moving on to bilirubin that we have already discussed, that direct hyperbilirubinemia is when conjugated bilirubin is forming more than 15% of total bilirubin. Unconjugated hyperbilirubinemia is when it is forming less than 15% of total bilirubin. One point to remember here is that a rate limiting step in bilirubin metabolism is not conjugation but the transport of conjugated bilirubin into the bile canaliculi, right? This is directly from Harrison, right? So now talking about the enzymes. See, these enzymes, when we talk about these enzymes, they are normally present in the blood but in lower concentrations, and when there is a liver injury they are elevated. So there can be enzymes of two, we can classify them into two categories: enzymes that reflect damage to the hepatocytes and enzymes that reflect cholestasis. So enzymes that reflect damage to the hepatocytes would include ALT and AST. So aspartate aminotransaminase and alanine aminotransaminase. So aspartate aminotransaminase, that is AST, is non-specific for liver because it is elevated in a number of other organs. If there is an injury to all of these organs, cardiac muscle, skeletal muscle, kidneys, brain, pancreas, lungs, leukocytes, erythrocytes, so it is not very specific for liver. But ALT is produced only and only in liver. So therefore, it is very specific for liver. Their normal range is 10 to 40 international units per liters, and levels up to 300 international units per liters are non-specific, and higher are more specific for liver injury. But the amount of enzyme elevation does not reflect the severity of liver injury. They do not correlate with the severity of liver injury, right? And more than 1000 international units per liter are very specific for viral hepatitis, ischemic liver injury, and drug-induced liver injury that we have already discussed, right? And usually ALT is more than AST, so the ratio AST to the ALT is less than 1. But in alcoholic liver disease, this ratio is more than 2:1, right? So this is very specific for alcoholic liver disease. Why? Because AST to the ALT. So this requires pyridoxine for synthesis. Pyridoxine is vitamin B6. Alcohol inhibits its absorption in the intestine. So therefore, ALT is low in alcoholic liver disease, causing this ratio to be more than 2:1, right? And this SGOT, SGPT or ALT, AST is usually not elevated in obstructive jaundice, except transiently elevated during acute phase of biliary obstruction caused by passage of gallstone in the bile duct, right? So this was about the SGOT and SGPT. Now coming on to the enzymes that reflect cholestasis. So that include alkaline phosphatase that is secreted from the bile canalicular membrane, 5' nucleotidase also secreted from the bile canalicular membrane, GGT that is present in endoplasmic reticulum of hepatocytes and in the bile duct epithelium, right? So these are the three enzymes that would reflect cholestasis. So the important question is, apart from liver, where all alkaline phosphatase is secreted? So it is also released from bones. So in individuals with more than 60 years of age, there is mild elevated ALP. So usually 1 to 1.5 times normal. Also in children and adolescent undergoing rapid bone growth, there is elevation of alkaline phosphatase. Then it is also released from the small intestine. So patients with blood group O and B have a transient influx of intestinal alkaline phosphatase in the blood after a fatty meal, right? So it can be raised in that condition also. In normal pregnancy, it is released from the placenta, so it can also be raised in pregnancy. So these are the four organs from where it can be released and can cause an elevated alkaline phosphatase. But when it is from the liver, it would be in association with elevation of GGT 5' nucleotidase, but there would be isolated elevation of alkaline phosphatase when it is released from bone, small intestine, and placenta, right? So again, less than 3 times elevation is not specific for cholestasis. More than 4 times elevation is seen in cholestasis. And elevation of liver alkaline phosphatase in the absence of jaundice or elevated aminotransferase suggests early cholestasis, or there is a hepatic infiltration by tumors or granuloma. So isolated ALP, when it is elevated, we discussed that it could be either because of bone involvement, small intestine, placenta, or it could be early infiltration by granulomas, specifically in sarcoidosis. Right, so we can get early isolated ALP raised in sarcoid also when and in TB also when it is infiltrating as granulomas in the liver with a normal bilirubin with a normal SGOT, SGPT levels. Right, so this is one thing that we should remember. Now, moving on to other investigations apart from this was all about LFT that we discussed. Now, what are the other investigations that are needed to diagnose a patient with chronic liver disease? So, first is ultrasound abdomen that we get done. So, what do we understand in an ultrasound? That it can show us whether there is a fatty liver or not, whether there is distorted liver architecture or not, which is suggestive of a chronic liver disease, whether the bile tree is dilated or not, right? Whether there are gallstones or not, whether there is any space occupying lesion, and then we can get with Doppler we can see the patency of portal vein, hepatic artery and hepatic vein. So all these things can be checked by ultrasound abdomen, right? Now earlier after this LFT report, ultrasound report, if we were suspecting cirrhosis, in order to confirm the diagnosis we would have to go for a biopsy. But now there are a number of non-invasive tests that can detect hepatic fibrosis, and therefore the need of biopsy has gone much down, right? So these non-invasive tests are very important. So they include first transient elastography, that is the fibroscan, MR elastography, and two blood based tests, that is APRI and FIB4. Let us discuss them. What are they? So APRI is AST to the platelet ratio index. right? So what is it is doing? We take the AST of the patient, then AST upper limit of normal divided by the platelet count into 100. So there are a number of cutoffs that have been used. So these cutoffs will vary as soon as the as and more and more data is available on them. So currently, the higher the value, the more specific it becomes for a diagnosis of cirrhosis, right? AST to the platelet ratio index. There are a number of online calculators also available that we can use for them. Then this is another very important calculator, the FIB4 calculator. So we should know what all parameters we are using. We are using age, we are using AST levels, we are using platelet count and ALT levels. So again, a FIB4 of less than 1.45 has a negative predictive value, that is to rule out cirrhosis of 90%. And the FIB4 values of more than 3.25 have a 97% specificity and a positive predictive value of 65% for advanced fibrosis, right? So again, higher values would mean a higher chance of cirrhosis of liver, right? So these are two non-invasive blood-based tests, very simple to do, which can help us to corroborate whether there is a cirrhosis or not, right? So liver biopsy, as I said, is now restricted for patients with acute liver disease whose diagnosis remains unclear despite medical evaluation, and patients with chronic liver disease whose diagnosis remains unclear despite medical evaluation, and also for staging and grading of liver disease, right? Now, once we have talked about how do we diagnose a patient with chronic liver disease, now the next step is to see his score, that what is it, which grade of child bug scoring is the patient lying in. So this is a very important scoring, the child bug scoring system, to see the 1 year survival and the 2 year survival of patient presenting with chronic liver disease, right? So this is a very important score. All of us must learn this score. So it includes these 5 parameters: neurological, that is encephalopathy, ascites, bilirubin, albumin, and protein value, prothrombin time. So 1, 2, and 3 scores are given depending upon in each individual parameters, whether ascites is none, mild to moderate, severe, bilirubin values, albumin values, PT values, right? And then this is totaled all these 5 values, and we calculate the total points. And depending on that, we say which child bug grade it lies in, right? So, for example, child A would carry a 1 year survival rate of 100% and a 2 year survival rate of 85%. But child C has a 1 year survival rate of just 45% and a 2 year survival rate of just 35%. Right. So, this is a child bug score that we must know when we diagnose a patient with chronic liver disease. Now, coming to the MELD score. This is another important score. So, this includes these 4 parameters: serum bilirubin, INR, creatinine, and sodium. So again, this MELD score tells us the 90-day mortality of patients with chronic liver disease. So depending upon the score, these are online calculators. This is the score, and we can see what is the 90-day mortality of the patient, right? So whenever we write a diagnosis of a chronic liver disease, this is for all of us, that when we are all of us patients who all of our medical doctors who are managing patients with chronic liver disease. So this is how we should write a diagnosis, so that we know everything about the patient in one summary. That patient has a chronic liver disease. So what is the index event? What is the year in which it was diagnosed? What is the child score? What is the MELD score? What is the etiology, right? And then what all are the complications, whether they are present or not. Taking the example, for example, a 42-year-old male, chronic liver disease, the index event was hematemesis, diagnosed in May 2022. Patient has a child class B, MELD NA 11. Etiology is ethanol related, has moderate ascites, grade 2 hepatic encephalopathy, does not have spontaneous bacterial peritonitis, has large varices but no active bleed is there. Coagulopathy is there, INR is 3.5, there is no hepatorenal syndrome, there is no hepatocolon syndrome. So this is how we should summarize for us as well as for the patient what all the diagnosis of chronic liver disease patient, and then manage each of these complications individually. Each of these complications would be dealt with in the subsequent videos. Thank you so much.